On this episode of the Ask Mike Reinold Show, we talk about vibration therapy, we talk about injury patterns as we age, and we talk about movement screens that are specific to each sport. The Ask Mike Reinold Show. Helping people feel better, move better, and perform better. Welcome back, everybody, to the latest episode of the Ask Mike Reinold Show. We're up at Champion PT and Performance in Boston, Massachusetts. Lenny Macrina, Dave Tilley, Dan Pope, and Mike Scaduto.
Is that weird I'm on the left this time?
I had something wrong with my vision. I had to like back up to see if that was Dan Pope.
Dan? Dan, is that you?
Yeah, no doubt. I'm definitely getting old. We're up here answering all your amazing questions. We got a lot of questions the last few weeks. This has actually been a good few weeks.
New year, new you.
So yeah.
Not to date them.
Yeah. So we're good. Lots of comments, by the way, on my facial hair. I think everybody's enjoyed my facial hair progression.
I like the gel. The gel is back.
I'm not. It's
Yeah.
Is it
pomade?
Pomade?
Yeah.
I don't know what it is.
The long-haired Mike with slight curve of the gel.
You like that?
You're just jealous of K-Mac.
I'm back, baby. John LaRue put a comment on Facebook about all my hair. It was awesome.
I got something yesterday.
We got some amazing students. So K-Mac, Kevin McNamara from the Fitchburg State University. That's not in the state that it's in
Franklin Pierce.
Franklin Pierce.
Not in the state of not in the state of Fitchburg.
Franklin Pierce, University of Phoenix, of New Hampshire. It's a weird one for us.
It's a lot of words.
So Franklin Pierce is up in New Hampshire, but apparently they have a satellite in Arizona.
That was one professor that was like, I'm sick of the cold weather, I'm going elsewhere.
I don't blame him. So K-Max here from the University of Phoenix in Franklin Pierce, Fitchburg State, Alabama. We're here. I'm getting worse at these introductions.
Yeah, you're bad.
And then Jan Conklin from New York Medical College. Nice. I literally just met her 20 seconds ago.
Gymnastics takeover.
so this is Jan's first day. Real wide eye experience, I'm sure.
Towson Gymnastics.
I can already tell she's going to be amazing. I can just tell. So
because she's a gymnast.
So K-Mac, do you want to introduce the first question? I can't see you. You're like right behind me. But yeah. K-Mac, you want to get started?
So first question is from Anthony in California. What are your thoughts on vibration therapy in reference to these handheld vibrating massagers as an adjunct treatment in an outpatient orthopedic setting?
All right, so what are our opinions on vibration massagers as an adjunct treatment in the outpatient orthopedic setting? I kind of like the way you phrased that.
I just use it only for everybody. That's it. Why adjunct? I would just use it for no, I'm kidding. I know that's what people are going to say, right? So that's good that he said adjunct because it's one small piece of the puzzle, right?
I feel like he's already...
Right.
He predisposed our question, which is fantastic.
Right.
But, all right, vibration therapy. Do we use it here at Champion?
Yeah.
Yes.
Yep. Okay, right? We use it. We've tried a bunch of different devices. We're currently using the Hyper Ice. What's the thing called? The
Hyper Ice.
It's the Hypervolt by Hyper Ice.
Yeah.
The handheld trigger thing. I've used them all. I was using the DMS. I don't even know what that stands for. I don't know, 10, 12 years ago. That thing's like $2,500 still for a thing. The thing's amazing, by the way. But I've been using these for a while. So who wants to take the first stab as to why we use it?
That's Dave.
What does that mean, Len?
Well, so, all right, let me start off. I feel like we say this on every episode, but a lot of people on Instagram will not only disagree with you, they'll probably try to shame you and make you feel like you're a bad human if you use one of these.
Yeah.
Does anybody...
I love that. I'm ready then.
Does anybody want to answer the question based on that? Because we all said we use it, right?
Yeah.
Does anybody intentionally not use it?
No.
All right, so why do we use it?
There is good research, and this is actually ironically from Dr. Sands in gymnastics, that if you do like static stretching on vibrating plates or force plates or things like that, it can help modulate sensation of stretch and thus increase range of motion temporarily.
Right.
So it's like a neurological override, I guess, or it just helps kind of trick some of the proprioceptors. So it can allow you to maybe relax a little bit more. Who knows? There's some deeper thoughts in that. But that and some blood flow is probably where I guess I've read that. But again, that was like a static hold on a vibrating force plate. It wasn't direct. So I think the theory is maybe reduce some tone in the soft tissue, increase some blood flow, get the water content shifted around a little bit. Feels kind of good, especially as a practitioner. It's sometimes hard to do a lot of manual hands-on work all day long for like bigger people who are sports and athletics. So all those things are reasons why I think we use them. But again, it's flexibility has multiple parts that need to be worked on. It's not a permanent thing. You know, we're not just gonna sit there and do that for the half hour. We're not gonna just rely on it.
I'm sold.
I'm in. All right, so we know scientifically that it's been shown that vibration helps increase range of motion
Temporarily.
Temporarily. We don't know how long, do we?
There was, I think it was a decay of like an hour maybe, but the studies are all over the place.
Yeah, I don't remember. I guess there's so many different ways to do. By the way, that's why studies like this are never going to be perfect. By the way, there's a million ways to write up the methods for something.
There's a million factors.
Yeah, there's so many things. So we know it helps with range of motion. Is it permanent? Are we giving them a crutch to lean on, or?
I would say we're giving them a temporary crutch to potentially lean on, so then you can exercise them and do what you want to do with them, so that maybe they feel a little better, can get a little bit more range of motion temporarily in their deadlift, or whatever you're trying to do, some kind of hinge or anything. I don't know why I just chose deadlift, but that temporary improvement in pain and maybe a little bit more flexibility is going to allow them to exercise and load them, and then maybe you keep riding the wave.
And this is my kind of combining off that is, this is with all tools that come out in social media buzz, especially with the ability of marketing now. The problem is that people are taking the tool and they're using it without a diagnosis, and they're using it on themselves to fix an issue. And that's the problem that I see, is like we see some videos on Instagram, people are like, oh, I feel tight, and they're literally doing it over their biceps tendon or the front of their shoulder, and you're like, whoa, like that's not, like if you use it to replace medical care, you're gonna get in hot water fast.
Right. And we don't use it to replace medical care here in our hands. No. It's an adjunct, which I think, what's his name again, Anthony? That Anthony said quite well. So it sounds like Anthony wants to use it, but is kind of feeling weird about using it, probably because a lot of people are telling him not to use it. But it's a very small adjunct. I mean, if you're a physical therapist or even personal trainer or whatever, and you're relying on this as your primary treatment method, then yeah, that's definitely not intelligent.
Like anything else. It's ultrasound, it's laser, it's instrument assisted, it's manual therapy, it's anything else that we do that combines with exercise. So why not just, if somebody likes it, I say go for it, especially if they like it.
So what do? They feel better, they move better. Right. So we can get probably a little bit more compliance and maybe a little bit more out of their loading that we're gonna do soon afterward. If you're working with an athlete and that gets them to feel better, to perform better during their sport, especially if they're getting paid for it, right? Or especially if a scholarship's riding on, or maybe they're trying to get drafted or something like that, then yes, those are the types of reasons. But Mike, Dan, anything else you guys want to add to the discussion on this?
I mean, I think you guys covered it pretty well from my end.
Oh, thanks, Mike.
Yeah, no problem. I don't really have much intelligence to add. To be honest, I think it feels pretty good, and it gets muscles to relax maybe a little faster than using a standard foam roller. I know that's purely anecdotal, but when I roll in that thing, it just seems like things feel better faster than with a standard foam roller.
Yeah. I personally have a lot of delayed onset muscle soreness that I deal with, like in my legs and stuff like that. I have one at home. I use it almost all the time. I feel amazing afterwards. So, why wouldn't we use it?
I tried to go with the classic answer. It's another tool in the toolbox.
A lot of people don't like that statement, though. But good, right? I think that's good. I mean, look, as long as you're using it and you understand that it has limitations, but it's just a very, very small piece of what we do for people. If it helps you achieve their end game, and their end game is feeling better and moving better, and it helps you load those patterns, and it helps you return to sport or whatever it may be, then if you use it well and you don't create like this dependence on it, then it's a very useful adjunct, like you said. Adjunct. It is not a primary treatment, right? Make sense?
Makes sense.
Love it. Awesome. What's number 2? Jan, first question.
Matt from Australia. Is it just me, or am I seeing a very similar pattern of injuries across all ages of youth athletes? For example, Seaver's disease at age 11, Achilles tendinopathy at age 14, and Achilles tear at age 18. Is this a coincidence, or are these related medical problems a buildup of overuse across multiple years? That's
a fantastic question. But before we answer it, Jan, that was an impressive first question.
Well
done. Huge addition to the team for the next few weeks.
Hashtag Jimmy's takeover.
I don't know how many we're recording right now, but yeah, that was Very, very well done, Jan. So, all right. So, what do you guys think? I thought this was a cool question. So, this person, which means they're not a rookie, right? This isn't a new grad, and this is where new grads, young clinicians don't get to see some of these things, right? They've noticed that in their patient population, that certain people over a 6, 7, 8 year period will have these progressive pathologies. So, you can't be a new grad, right? You have to be treating for 6, 7, 8 years to be able to see this. So I think that's an interesting perspective. It sounds like, what's his name again? I'm sorry. Matt, that's Janet. So this is actually interesting that Matt brings this up, right? Because this is a cool question. So look, Dave, you've worked in gymnastics, and Dan, you've worked with a lot of these like high-level fitness people. Do you guys agree with this, or do you think this is an isolated thing?
Yeah, I mean, I agree. This is a theory that's definitely what I'm kind of wrapping my head around now. As I have written a couple longer medical presentations for organizations about, you know, gymnastics injuries over the lifespan, I guess, because the biggest problem that a lot of youth sports, and we'll steer it away from just gymnastics, a lot of youth sports are pushing so hard in the 10 to 18 range to go to college or do whatever that they break themselves in the process of getting there. And I can now say, again, I have 5 years kind of here looking at it, and I've unfortunately seen 2 athletes that I work with, one a gymnast, one not, who worked so hard to get a scholarship that they got to their D1 university and didn't compete the first 3 years because they were like snowballing so many injuries. As a stress fracture 1 year, as a slap to the second year. Who knows whether that was the college and the organization, but you get a lot of baggage you're carrying with you. And I think it all comes down to the forces of the sport are here, and you're just attacking the most vulnerable spot as you grow, right? So when you're under 12, 13, whatever, and you're prepubescent, it's callous bone is not yet formed. It's very soft, like at risk. So that's the weak point, and all the force goes through there with a variety of other factors about your physical prep and whatever. Okay, so maybe your bone growth plates close, you get 2 more years down the road, but you're still carrying those injuries with you. And then now it becomes, okay, the patellar tendon is the issue, right? Or the Achilles tendon is the issue, and the growth plate is no longer taking the force. Well, now you get an Achilles tendinopathy.
Right. And
then you go through these massive flare-ups of deload, upload, and you go through bouts. Then, okay, now that gets better. You get to college, you're a fully mature athlete, you're doing your hardest skills, you're training at a harder volume, you're competing at a harder volume, and you tear your Achilles, because like the tendon finally kind of breaks down and goes through. You tear your ACL maybe from a progressive overuse kind of mechanism or something like that. So I really think that we're seeing the exact same injury over and over and over, just in different shades.
Right. So it's, you know, sometimes that person is predisposed to this for some reason. Right. Maybe it's anatomical. Maybe it's a collagen issue on the inside. I've actually seen some people with weird
cartilage stuff,
like muscle diseases, right, that you would have never diagnosed. So maybe you see that, but you know,
you guys probably see that in baseball too.
I was going to say,
of course.
I know they talk about setters and all that, but if you have a growth plate injury, like a Little League's elbow, there's a really good chance that you're going to have a Tommy John surgery later in your career. So.
Right. And anatomically, you could have a very large carrying angle for something like that.
And there's many factors,
to, you know, or maybe it's just you just didn't learn your lesson and you're still overloading. These are all overload injuries, right? Dan, what do you want to add?
I was going to say that I see a lot of the same, but I see it on the other end of the spectrum. So I see a lot of, like, let's say CrossFit athletes or just recreational athletes, powerlifters, bodybuilders, whatever it is. Let's use like the hip, for example. So in a young individual, you may see some more FAI or some labral pathology. As they start to age, you see more and more labral pathology, and it turns into osteoarthritis.
Right.
In the shoulder, you might see some impingement or some tendonitis, which eventually turns into tendinopathy, eventually turns into tearing, you know?
Right, which eventually turns into osteoarthritis, which eventually turns into just you not liking life.
Yeah,
right.
So I think it's like this similar mechanism, right? So if maybe your squat programming is a little off, right, and you have a big cam deformity and you're doing a lot of forced flexion or internal rotation or whatever it is, over the course of time, you're just going to get more and more wear and tear, and then you just see more and more advanced problems as someone ages and continues with whatever they're doing.
Right. So it seems like, you know, your goal, well, how do we break this cycle, right? Well, when you identify somebody early, now that you're experienced, Matt, which is fantastic, you know, this isn't the first time you've seen it, maybe we can start this education process that starts telling them, you know, it's almost like we have two things to do. It's like, how do we increase the capacity of the body to be able to handle these things better?
Yeah.
But also is, how do we manage your workload better? Because if you're having these overuse injuries at such a young age, you're probably not managing the workload very well. And it's going to continue to build over time. So I think that's pretty important. I also think that's why it's quite short-sighted to say that asymptomatic people with MRI findings or something like that will not progress to anything further. I mean, we've actually shown that to be quite the opposite. I think, you know, one of the things that everybody likes to talk about is the spine, which I think is a completely different game.
Yeah.
But we have quite obvious documentation of progression in the joints like the shoulder and the knee and the hip, that these asymptomatic things can progress over time and cause more problems down the road. So again, it's short-sighted to just see one post on Instagram and think that just because people with discs are asymptomatic, that doesn't mean all MRIs are irrelevant. I mean, that's very short-sighted. So we should really put all of these pieces of the puzzle together, I guess. Yeah. So, but workload management, right?
Definitely.
Yeah.
It's a whole relative risk versus absolute risk.
Right.
The risk of getting arthritis if you have a cam deformity or labral tear is still really, really low, but you're much more likely to have it than someone who doesn't have that pathology via MRI findings.
Right, absolutely. The cuff one's amazing to me too, but maybe it's just because I deal with so many shoulders, but like when people are like, oh, lots of people have an asymptomatic cuff tear. I'm like, well, yeah, like when you're 35, but that's going to be a problem down the road. That person's going to have more arthritis. That person's going to probably end up getting like a reverse shoulder now, and that's a big deal if we ignore it, say that's normal, and just work through it and pretend it's not there because that's crazy to do anything else. It's just very short-sighted. There are plenty of people that do well, that are asymptomatic with diagnostic imaging, right? But I don't know. I think we could do a better job trying to educate and prevent down the road in the future. Awesome. We got one more.
One more.
K-Mac.
So Isabel from Minnesota has another question for Dave. How do you perform movement assessments on different sport athletes? How do they differ from other sports? And is there anything in particular to be on the lookout for? I would love if a gymnastics professional could answer this question.
Lenny, sure.
All right, let me get into this.
Lenny thinks it's just about more double giants on the tumble track. That's really the.
Why don't we answer this generically
Yeah, for
and
sure.
just say like, all right. So do we do a movement assessment here at Champion?
Yes.
Yes.
Okay, so we have a baseline movement assessment that we think everybody should do, and it kind of captures all the basic movement patterns, right? That's like our baseline one. It's very good for our adult fitness. It's very good for most of our athletes and our PT clients and stuff like that. But when you have a specific sport, do we do anything different? Dave, do you do anything different for your gymnast?
Yeah, I mean, I would say I do for us, and if you spent a couple weeks in the clinic, you would see all of us fall. 70% is an overlapping of val that all of us do, and then 30% of us have whatever our sport demands, right? So Lenny and Mike are going to look at total range of motion in a shoulder to make sure it's matching for what a baseball player needs. Mike's going to look at a hinge assessment. He's going to look at some things from maybe the TPI. Dan's going to put somebody in a front rack. I'm going to maybe look at somebody in extreme hip ranges of motion, right? But that's 30% of our assessment.
Right.
So that's going to be like, okay, we have most of what we need for you to be a human and an athlete in general. What are the specifics of your sport that you need? And I have been fortunate to talk with many people who have a lot of other systems as well, and they say the exact same thing. It doesn't matter what system you're using. They say like, this is the base, it should help you, but then use your brain and try to figure out what's more. And and if you're looking for gymnastics one, I do have a blog post where I literally filmed myself walking myself through some of our assessment, and then also my own thoughts, but then also a lot of gymnastic specific stuff, so you can find that. I'm sure these guys would help you out if you're looking for a golf one, if you're looking for a baseball one, whatever it is.
Right, so we're all humans, right? So we all have the basic fundamental movement patterns, but then maybe we use our body a little bit specifically for a sport. So how do you do this? I'll kind of summarize this quick, actually, because I think this is an easy one. How do you do this? Well, you should have a baseline functional movement assessment that you follow, that is what you think is appropriate to monitor how well a person's moving, right? So there's many out there. There's a bunch of different things. We have a specific one we use here, but that's our like baseline, right? From there, if you're working with a specific athlete that has a specific sport, the first thing you need to know is the unique demands of that sport. Once you understand that, it's really easy. Like if you look at the TPI assessment for golf, right? It's like, it's not complicated, it's not crazy, but you have to know what a golfer needs to be able to assess them most appropriately, right? So you have to embrace it. You have to probably be a golfer yourself. You don't have to be a golfer yourself, but you got to really, really immerse yourself in that scientific thought process of what the body needs to perform in that sport, and then figure out tests to be able to quantify that. And it's really that simple. So you don't have to like find a magic one on the internet. You just got to think like, what do you think is important in that sport, and how do you quantify it? And I'd say that would be it.
And the only other thing I would say is don't be afraid to innovate a little bit if it's not in the research. That's the thing that I see a lot of people who get stuck.
There's nothing in the research.
Yeah, right. Because you're not going to find a ton of stuff that's relevant until 2 or 3 years down the road when they do it. So like, I have some stuff that I'm like, I think this is what's appropriate. You guys, the same thing, but just don't like.
Step one. We can go through our 20-year history of baseball. Step one is figure out what baseball players are supposed to look like. So step one, figure out what soccer players or golfers or whatever, figure out what they're supposed to look like. Once you know what they're supposed to look like, and sometimes it's not what you necessarily think, you start having to like create this database, either mentally or whatever, a real actual database, but you got to know what that person looks like. And then step two, it says like, all right, well now that I know what the ideal person looks like, or the normal or the mean looks like, then what tasks do I need to do to make sure that this person's fitting within that realm, right? So like Dave said, you're not going to find this in the literature. You're not going to find something magical. And most of the movement assessments in the literature are trying to predict injury, and I don't know if that's really what we're shooting for. So awesome. Makes sense? Awesome. Great. Another great episode. Thank you so much for your questions. Get a bunch of great questions, a ton this last month, so keep them coming. We get some great ones coming, and we'll see you guys on the next episode. Oh yeah, wait, I'm supposed to say, go to MikeReinold.com, click on that podcast link. You can ask us those questions, and go to iTunes. You can rate, review, and subscribe to us. We'll see you again. Thanks.